Hi, welcome everyone, and thank you for joining us for the COVID-19 vaccination Q&A session today. My name is Hanan. I'm a local resident of White City and Wormhole, and I'm very passionate at making positive changes in my community. Also, I'm part of Imperial's Agent of Change network, and it's a leadership network for women driving social change in the north of Hammersmith and Fulham Borough. So my job today is being your host and making sure that we're on track and asking as many questions that have been pre-submitted and that are being submitted in YouTube and via the Gmail. So let's get started. If there's any issues, we've got a great team who will be actually checking the questions, so they'll be able to help you. And just please remember to be respectful in the chat, and just to make sure that we make it as enjoyable for everyone. So I'm firstly going to introduce our researchers. I'm going to start off with Liz.
Hello.
Hi Liz, how are you?
I'm good, thank you. How are you?
Great. Could you tell us a bit about yourself, please?
Sure. So my name's Liz Whittaker. I'm a paediatric consultant at St Mary's Hospital in Paddington, and I'm also a lecturer at Imperial College, where I do research on how the immune system of children interacts with different bugs, including COVID, and that's why I'm here today with a bit of data on that.
That's great. Thank you for being with us. And I'd like to also introduce Paul.
Hi.
Hi, Paul. If you could tell us a bit about yourself as well.
Sure. I'm a senior research fellow at Imperial College, also at the St Mary's campus, the same as Liz. And I've been working on vaccines and developing vaccines and the technologies that underpin vaccines for many, many years. And this last year, I've been working on the COVID-19 vaccine, the self-amplifying RNA that is able to induce an immune response. And in animals and also in people, and it will be similar to the Pfizer-BioNTech one and the Moderna vaccine.
Right, that's great. Are you both ready for the questions? Because they're coming in fast. Right, so we'll start off with, I've got a question that's just come through, and it says, from Steve, is it safe for women to have vaccine if they are thinking of having children? So I guess this is all about fertility. Should we go to Liz?
Yeah, I'm happy to take that one. Thanks. Get started. So, hi, Steve. Thanks for the question. And I know this is something that lots of people are worried about. I get this question all the time from people I work with on the ward, from nurses and junior doctors. And there is no reason to worry about having the vaccine if you're a young woman who might be having babies in the near future. We know that there were some myths going around about how it might impact on fertility, but there's no evidence that that is true, and there's no reason why or how a vaccine could do that. And I think we were saying earlier, it's probably based on the fact that it's got RNA in the title. It sounds like genetic, and we know that genes and babies are all kind of linked, but actually there's no scientific reason why that would be a worry. And in fact, you know, we'd quite like people to be vaccinated before they get pregnant, so that if there is any risk of being more unwell when you're pregnant, you can bypass that because you've already got some protection, and you'll have antibodies to give to your baby, so they're protected when they're first born too.
Fantastic. Can I just ask, what does RNA stand for? Because I'm sure many don't know what it stands for.
Definitely a Paul question.
So RNA is ribonucleic acid. It's basically the similar to DNA. We all know that the DNA is in our center of our cells, in our nucleus, and RNA is the message code from the DNA, and it's simply intermediary between the DNA part of our bodies and the protein part of our bodies. So the RNA just makes the protein. It's just a message. It's like an email.
Fantastic. Thank you. Another question that we have, in the event you may get COVID before the second dose and it's too close to the 12-week guide, what what happens? Do you start all over again, or what happens?
So at the moment, the recommendation is that if you pick up the virus in between your first and your second dose, that you wait 28 days after having the virus before you have another dose of the vaccine, to make sure that you're better before you start again. And your GP or your vaccine centre will be well able to factor that into the timing, so don't worry about it too much.
Fantastic, thank you, Liz. We have another question for Paul, probably. Where are we at the moment with the COVID-19 vaccinations?
So globally or in the UK? Because
I think maybe the UK for now.
So actually,
Make it a bit easier on you.
The global aspect is interesting, and maybe we'll come back to that. But certainly in the UK, we're doing really, really well at getting the vaccine to the population, and we've vaccinated over 30 million first doses and 10 million second doses. So we're already making great strides towards protecting all of our population from hospitalization and very severe disease. Now, of course, the vaccine doesn't stop you from contracting the coronavirus, so we still need to maintain things like social distancing and masks to prevent the community spread of coronavirus. But it does probably reduce your ability to transmit it to the next person. But most significantly for you as a person, it reduces very significantly your chances of being harmed by COVID-19. And harm isn't just death. Harm is in many forms with coronavirus. There's lots of organ damage, lung scarring, brain fogs, loss of smell, minor things to major things. And these are all, consequences of catching COVID. So yeah, we're doing really well with the vaccines. There's lots have been developed, and there has been now 4 that have been recommended for use in the UK. And while there's some restrictions on things like AstraZeneca, we are doing really well with the Pfizer-BioNTech, and hopefully the Moderna will come on at the end of this month. And also we still are using AstraZeneca for people that are over the age of 30. So we're doing really well.
Thank you. Well, this ties in from a question from Omar. I am under 30 years old and I've had my first jab, which is the AstraZeneca. Would it be possible to have an alternative brand administered?
I'm happy to take that one. So I think the current recommendation, so I think this is going to be because you're worried about having AstraZeneca because the guidelines have changed recently. That's because of this really rare clotting phenomenon that people have heard about. But actually, the very tiny number of people who've had a clot had it with the first dose. And so the current recommendation is that you should just have the second dose of AstraZeneca, and we don't think that that's a risk. But just going back to the clotting, if we'd like to talk about that maybe for a minute, that might be useful because I'm sure it's going to come up. So
there's a lot of questions,
which is vaccine-induced thrombotic thrombocytopenia, and that basically means and we don't really understand it yet, if we're honest, but what we think is there seems to be an association in a very teeny tiny number of people. So I think about 23 out of 30 million people who've had a funny clot. And at the same time, when they have the clot, one of the things that you measure in your blood called a platelet, which is what makes the clot, has gone down. So often when we get clots, those things go up instead of down. And it's a very unusual combination, and that's why it kind of stands out when they've presented. And these clots are extremely rare. They can happen in anyone in the background, but there does seem to be an association very rarely, as I said, 23 cases in about 30 million. So very uncommon that they could be associated. And for younger people under the age of 30, your risk of having severe COVID is lower than when you're older. And so that very tiny risk becomes slightly more important to you. And that's why they've changed the recommendation about which vaccine you should have when you were younger. However, if there were no vaccines available, I think you'd probably still be much better off having the AstraZeneca than no vaccine at all. And even the majority of people who've had the AstraZeneca under 30, and there's quite a few because of the healthcare and key workers and things, have been perfectly fine as well. Paul might want to add something, I'm not sure.
No, that's great. Yep, that's perfect answer.
No, that's great. Just wanted to add, as a reminder to everyone, if we don't get through all the questions, the team will be answering it after we're done. I have another question, and I do apologise if I pronounce the names wrong, but Mrs. Darley, are people who've had a previous thrombosis with varicose veins more likely to have issues with blood clotting from the AstraZeneca vaccine? If so, what advice would you give for their second dose? So I think this is more about the blood clotting and the fear that everyone has at the moment. Liz, Paul?
I'm happy to do that. So I'm going to pick this part. So there's two things here that you're asking.
Yeah.
If you've had a clot after the first dose of the vaccine, then you shouldn't have the second dose of the vaccine. If in the past you've had a clot that was of the type that this vaccine has been associated with, then they also would probably suggest a different vaccine. However, having clots with varicose veins is a slightly different phenomenon. I think clots are really common as you get older, actually. It's one of the things that people probably didn't realise. You start talking about things in the media and it was, oh, my auntie had that. So having clots with varicose veins is really common, and I don't think that will be something that would be a reason not to have the AstraZeneca vaccine. So for that particular question, just have the second dose. I don't think there's any risk associated with it at all.
Yeah, I mean, that's what I've read as well. The clots are there's lots of different ways to get clots, and the way that they're talking about with the vaccine is kind of specific. So having a normal sort of varicose vein clot is probably completely unrelated. But of course, you should always make sure that you have the advice of your own personal doctor for any decision of your medical any medical decision you want to make.
Fantastic. There is a question that I've been asked quite a bit, and it's to do with young children. Well, anyone under the age of 16, when will they be vaccinated? Because in our community and around, we see children, they're the ones that are the carriers of COVID, and they're the ones spreading it. So, yeah.
This is something I feel very passionately about. So there's two things here. One is that children aren't the people in the community who are driving the virus. So they actually get infected less often than adults. And when they get infected, they very rarely get severe disease. And actually, although they can pass on the virus, it's much more likely that adults pass it on than young children, just because you pass it on more when you're symptomatic, and children don't tend to get symptoms. And at the moment, we have started doing vaccine trials in children just recently, and we haven't got data on safety in children. We don't know what the right dose is in children, because children have slightly different ways in which they respond to infections to adults. We need to make sure that the vaccine works the same way in children before we roll it out. And at the minute, there's really no direct benefit to a child of having the vaccine, because they're not at risk of the real complications of COVID that we've seen in older people. And so we'd like to get more information on how the virus works in children before we make decisions about giving it to them. I think that probably we're really lucky we live in England and the UK, because actually we do great vaccine research in this country, and those trials are already underway, and we're hopefully going to have data either towards the end of this year or early next year. And then all the scientists and all those clever people can sit down and think about the best time and the best way to give vaccines to children. But it's best to get the information first.
So can I just add on to that? Why do numbers tend to rise when kids go back to school?
See,
this is what makes us believe that it's them spreading.
And it's very sensible. So we've had 3 lockdowns where we've closed schools, haven't we? And it's not like we closed schools and left everything else open. What we did was we closed everything, including schools. And so everybody stayed at home, everyone mixed less, everyone washed their hands more. And what were they doing before? Everyone started wearing their masks. And so all of the transmission stopped. And then when you open schools, people started mixing again, and all that transmission started happening again. And so it's not the schools per se that are the issue. It's the fact that we've changed what all the grown-ups around them are doing. So mum's able to drop the kids to school, and then she can go for a coffee with her mate. And, it's all that kind of activity that contributes to it. So I know I really want to get our kids not scapegoated. I think that it's really important they get back to school. They've had a really rubbish year. And so right now, let's get them into school, and let's pass the message on that it's adults need to be responsible for washing their hands and keeping away from each other to protect the children in school and themselves.
Thank you, Liz. Thank you for that. I've got a question from Jenny. What are the differences of each vaccine available? Is one vaccine brand better than the other?
Okay. So there's quite a few different vaccines available. If we just talk about the vaccines that are available in the UK, so the first one is the AstraZeneca. It is a viral vector vaccine. It's based on an adenovirus, which is a cold virus which circulates in the population. The Pfizer and the Moderna ones are both based on RNA. So they deliver a molecule of RNA that makes the protein that's on the outside of the coronavirus. And the other one that we're likely to get soon is the Johnson & Johnson, which is also an adenovirus-based vaccine. So the other ones in the different parts of the world, some of them are based on proteins, which are just from the outside of the virus. So there's lots of different types. But basically, saying that one is better than the other is not what we should be thinking about. We should be thinking about, do each of these vaccines protect us, and do they protect us well from the consequences of catching COVID-19? And the data really shows that yes, they do. So while we get figures for Moderna of like 95% and figures for AstraZeneca of like 70%, there's really not much difference on a personal level between those. They are effective. They are able to protect from hospitalization and disease. And so anyone that you're given, just take it.
I agree. And I just think, because I've seen it come up a little bit in the questions, is about if I get this one and then I'm offered another one. It's a really good point, because they, as Paula said, they work in slightly different ways. But there is a study looking at that at the moment in Oxford, which if you want to take part in, they're looking for people right now. So if you Google it, that'd be great. And what they want to know is it better to get two different vaccines? Does it make any difference at all? Does it make it less protective or more protective? And so that study's underway at the moment and recruiting to answer that question. We believe scientifically that actually probably it doesn't make a big difference. And we've done this it's not like in the vaccine world. So for hepatitis B, which we give to kids, sometimes you get supply issues and you give a different Hep B vaccine. It still works brilliantly against hepatitis B, for example. And so there's no reason that we think it wouldn't work like that, but it's really much better to do the trials to show that. As I said, the UK are a real leader in vaccine trials, and it's just brilliant that we'll have that data quite soon, and then there'll be less of a worry. We'll be able to say whatever vaccine's available, you should take.
Okay, fantastic. Paul?
I was just going to say that, of course, in the future, if we have to get a booster vaccine, it's quite likely that it may be a different type of vaccine. But there's absolutely no reason to think that would be harmful in any way. And they're all the same protein as well. Don't forget, they're all the same structure that they're targeting. So just because they've been delivered in a different way doesn't really mean a huge amount.
Thank you. All right, we've got a question that has just come in from Richard. Hannah had COVID in January and optic, I'm not good with pronouncing, is it?
Optic neuritis.
Right, in Feb. Her ON has caused by an unusual reaction of her immune system. The AstraZeneca, Johnson & Johnson vax could cause the IS to overreact. Should Hannah take any vaccination?
So I think
it's very technical, and there's a lot of jargon words.
I think there's a worry here that somebody's had an unusual condition after having had the vaccine. It's most likely coincidence rather than related. But I think rather than us who don't know very much about her condition, she should discuss it with her GP. So I think if you've got worries about your health, it's always much better to go and have a chat with your GP, because they have all of the information about what you've had in the past and last year and the year before as well. So I think that doesn't sound like something we'd be able to comment on today.
Right,
but on a more general aspect, though, having something that happens just close by to your vaccine doesn't have any indication that it's caused by the vaccine. There's no real reason to think that. And if you think back just about your own medical history, and you think back over the last year, the colds you've had, the aches and pains you've had, you know that there's many of those. And just because you got a vaccine 3 weeks before or a month before doesn't necessarily mean that that's got anything to do with it. So you can wind yourself up and make yourself over worry about things. But with all of these vaccines, they're always being monitored and watched as to what's happening after you get the vaccine, when a large group of people get the vaccine. So things that are, very rare, we should look at the clotting thing as a real testament to the ability of us to monitor what happens with the vaccines. It was an extremely rare event. It was picked up. We did something about it. We looked at the vaccines and we said, well, maybe we shouldn't give this to this group of people. So it's not as though we just don't pick things up and we don't see them and we don't do anything about it. We saw this and we did something about it.
Yeah. And that's got Paul's describing something called post-vaccination surveillance, because for really, really rare side effects, you can do 100,000 people in a vaccine trial, but if something happens in 1 in a million people, it might not happen within the trial. And so this thing called yellow card reporting, which is where your GP will have put in, or your clinician, whoever picked up that optic neuritis, will have gone back and said they had this event. And if it flags up, then it would become recognized. And that's kind of how the clot got recognized. So there are really good systems in place. Everybody who works in this area is really conscious of making sure that we're as safe as possible. And we'd really like to reassure you that that's the case and that there are good surveillance systems to check that out.
Good to know, thanks. I've got another question from Katie, and I think this might be for Paul. Is it true that the technology used in the AstraZeneca vaccine has been worked on for some time now, since pre-COVID, so it's not that new?
So the adenovirus as a vaccine deliverer is definitely not new. The professor that developed the COVID vaccine, Sarah Gilbert, has been working on this for about 20 years. So that's just one person working on it. I myself worked on adenovirus vectors in the 1990s. The whole technology is, things that have been tried and tested and used multiple times. Now, the differences between using them in a research setting or using them in a clinical setting. But there have been many phase 1 and 2 clinical trials using adenovirus vectors. In the same way, as people may not know this, there have been many phase 1 and clinical trials using RNA vectors, so the RNA technology. So the first one that was used was in 2013. And there was actually a RNA therapy that's already been licensed since 2018 for a very rare disease. So neither of these technologies are brand new, but of course the RNA is a newer technology. And because it was used for the first time on a large scale in clinical trials and in people for an actual vaccine, that's why people are so concerned about the RNA.
But the RNA, it's such a clever thing. And I think people who work in the vaccine world are so excited because it's really easy to make. We talk about the variants, somebody might ask about that in a moment. If the variants change the type of virus that's around, we can change the vaccine to address that very quickly and very easily, just pretty much by writing a different kind of email to the manufacturing factory that makes it. And at the moment, Pfizer-BioNTech, who made the first vaccines that were made, are doing trials on different types of the vaccine with the different variant in it already, to try and understand how different they would be. And it's likely they would work in exactly the same way. But that's the magic of the mRNA vaccine, is that it can be really responsive and change really quickly. And that's it's so exciting for us. I know we're like slightly nerdy, but it is an amazing step forward in terms of vaccines. And it may be that it was being used for Ebola and it was being used for various other things, and that we may be using this type of vaccine for the next 100, 200 years as we develop vaccines against other diseases. So it's very exciting.
I see it as like the clean energy version of vaccines, because it's so pure. It's very simple, not to make it sound trivial, but it's great technology, but it's very simple and clean. And there's very few ingredients in the vaccine. So it's much better, I think, than other vaccines, but I would say that.
Biased. I agree. And I think lots of people are very excited by it in the scientific world.
Just a question that I hear a lot, because there's so many variants out there. You've got now the India one, you've got the South Africa one. Does the vaccines now, the Pfizer, AstraZeneca, do they cover them? And if not, will you need a booster? Like, you know, there's a lot coming through that every 6 months you're going to need a booster. You know, these variants keep popping up every couple of months. You know, I don't know. I think it's going to be impossible to be vaccinating everyone every 6 months. I don't know. Yeah, I'll leave that to either Liz or Paul. It's a hard one.
Well, yeah, the variants are an issue, but there has been already quite a lot of work done to look at the immune response that has been generated to the original vaccine and how that is effective against the variants. So it's found that it is very effective against the UK one and less effective against South Africa. Medium effectiveness against Brazil. So you can see there's a sort of roller coaster of ones that it's effective against. There's no data yet on the India one because that's actually quite new, but it's likely that any variant will have some protection given to you by the original vaccine. Now, as Liz said, even with actually the adenovirus ones, never mind the RNA ones, people have already changed them to match the new variant. So if you match the new variants, then basically you can cover those. And it's thought that it's covered in exactly the same way, that it's just as effective against those. Will we have to have boosters every 6 months? Well, this comes back to what I was talking about, the global effort of stopping the pandemic. If we don't stop it globally, then there will be new variants that can arise and can spread. I think it's very unlikely that there will be a variant that totally escapes the original, but it is possible. But we can make a vaccine very quickly, and we've already done the clinical trials on a very similar vaccine, so we could roll it out really quickly, I think.
Yeah, and I was going to say there's two things. One is a myth-busting thing, which is, I know that's out there, is that people think that the variants are arising because of the vaccines, and that's not true, actually. So I think the way that you get a variant is if the virus is allowed to multiply lots of different times without being checked, and that happens in areas where people have no immunity and where there's no stops or checkpoints. And when people are vaccinated, it's like a stop, and it stops the vaccine from the virus from being passed on, and then stops it being able to multiply. So you're less likely to get more variants. So as we vaccinate more in the UK, it's highly unlikely that new variants will arise in our setting. And that's why we need to make sure that as much of the globe gets vaccinated as possible to prevent multiplication of the virus. So I sort of bust that myth, because I know some people think the two are related. And the other thing is to go back to what Paul is talking about when they talk about being efficacious. What's really interesting is we measure antibody, and you've heard a lot about that in the media. That's a protein your body makes in response to the vaccine, and the antibody is the bit that's very specific to the variant. But we also make T-cell responses, and at the moment we haven't been measuring those because they're a bit more complicated to measure in the laboratory. And the T-cell responses, which are like your fighter cells that they may actually protect against all the variants. And so there's ongoing research to look at that, and they last a lot longer than antibodies. So it may be that the booster isn't needed at all. Now, that was probably a bit overly technical, but just to say that it's probably an even glossier, better picture than it sounds like from the scientific perspective. And I think in the scientific community, we're not so worried about it. And we know that there's going to be new data coming forward that I think will be quite reassuring.
Yeah, I think that's a really good point, Liz. Science. Yeah, because the T-cell responses, I think, are quite strong for this vaccine.
Yeah. So lots to learn, lots coming out. It's just amazing. I think the real thing here is if your kids are into science, this year has been just so exciting from a scientific perspective. I mean, awful from so many ways, but the way that the scientific community has worked together across many different countries has just been really lovely to try and do what we can to stop the pandemic. So that's really nice.
That's great. Okay, I've got a question from Ray. Relevant to what you've just been talking about. Are vaccines effective if one has an autoimmune disease like lupus, and or if one is on autoimmune suppressant drugs?
So this is a really important question.
Yeah.
So having an autoimmune disease in its own right doesn't necessarily mean you'll respond less well to the vaccine, but some of the treatments we use for those conditions may suppress your immune system. Actually, a lot of people who are on those drugs have been part of trials and have made good responses, but we are doing specific trials in people on those treatments to understand if the responses are as strong and last as long. So that is a group of people who might be a little bit more vulnerable, might need earlier booster doses, and that is something we don't completely know as yet. We do know about vaccine responses in immunosuppressed people from other vaccines, and we know, for example, for HIV, that people with HIV are well able to make really lovely antibody responses, and that other immunosuppressive therapies don't affect your ability to respond to vaccines. And so it's likely that there'll be protection, but I think it's really important we know that for definite, and that's why those trials are ongoing.
Fantastic. Thank you. Paul, I've got a question for you from Meakin. Any update on the Imperial vaccine? Real world results show that mRNA vaccines are more effective, and the Imperial vaccine, one of only about 5 in development.
Yeah, so our Imperial vaccine, we did phase 1/2 clinical trial, and we saw that the responses were quite good. They weren't as good as the responses seen with the other RNA vaccines from Pfizer and Moderna. And we had a larger number of what we call in the vaccine world non-responders. So the reason for that is likely to be the difference between the RNA used in our vaccines, in that the Pfizer one and the Moderna one used messenger RNA, and we used self-amplifying RNA. And we think the self-amplifying RNA was seen by the body much quicker and got rid of much quicker than the messenger RNA vaccines. So while the messenger RNA vaccine is small, it is able to produce lots of protein. And our concept as Imperial was that we used this larger RNA called a self-amplifying, which was able to replicate itself, with the idea that we could use less of a dose to get the same response. And it didn't turn out that that was the case, but we are still researching on that, and we're still looking into the reasons why. And so for us, using this new technology, we were able to get a good first look at it as what happens in people, and we're going to be developing it further and continuing to improve our vaccine.
Thank you. Another question as well, but probably Liz will be able to answer this one. A lot of concern about fertility, breastfeeding, pregnancy. It's only just come to light now that pregnant women can be vaccinated. But again, concern of women that are breastfeeding as well. Can they have it? Shouldn't they have it? So yeah, it would be lovely if you could sort of
yeah. So we touched a little bit on the fertility thing earlier, which is that we've got evidence that affects your fertility. But in terms of pregnancy, particularly in the 2nd and 3rd trimester, we actually give a number of vaccines in that time period at the moment. So we give the whooping cough vaccine, the pertussis vaccine, and we give the flu vaccine. And we plan to give those in pregnancy on purpose, both to protect the pregnant woman, but also her baby. Because when you're pregnant, you make those antibody proteins we're talking about, and they go into the baby's bloodstream and protect the baby when they're born. And so we know that vaccines are safe to give in pregnancy, and we recommend them. And we are happy and confident that this vaccine is also safe to give in pregnancy and will give some protection both to the mum and to the baby when it's born. And so we really recommend that pregnant women, particularly in the 2nd and 3rd trimester, would go ahead and have that vaccine. And if you have got questions, your midwife or your obstetrician or your GP, I'm sure, would be happy to talk to you about that. With regard to breastfeeding as well, proteins that your body makes, the antibody, can also be passed on in your breast milk. So again, it's a nice way to protect your baby. And we have no indication that there'll be any reason for the vaccine not to be safe to have while you're breastfeeding or pregnant at all at this time.
Fantastic. Thank you, Paul. Anything
to add nothing to that?
Or like Liz? Yeah. Right, okay. We've got a question from Mahia. Antibody testing. Can you please elaborate on this, as we are not having a clear picture of the technique used to test it? Paul?
So are they meaning the test kit or the way that we look at antibodies in people?
It's
not
not
really
quite
sure.
clear, but maybe shall we go with the test kit? Maybe.
Yeah. So the lateral flow test basically just detects whether there's antibodies in your serum, or that you've swabbed off from your surfaces and put into liquid and then dripped onto the strip, and it just tells you whether there's antibodies present, whether you're got some reactivity against coronavirus. We do things differently for assessing what happens in the clinical trials. We look at the levels of antibodies in the blood, and we try and determine whether those levels of antibodies are protective and correlate that to if somebody gets infected, and correlate that also to their disease outcome if they become infected. And of course, there's not just antibodies, as Liz has mentioned, there's also T cells, which we do also measure, but as we know, there hasn't been as much details on the T cell aspect of these vaccines yet, but there will be.
Yeah. And I just think so that antibodies it's really funny because I think when you do science and you work in immunology all the time, you forget about what's normal to know and what's not normal to know. So I guess the antibody is basically what your body makes to protect you from infections, and you can measure it in a finger prick drop of blood or in a blood test taken from the vein, but also, as Paul was saying, in your mouth. And obviously you have antibody that's in your nose and mouth that then is the first barrier of defense against the virus as well. And so what's been looking at is the different types of antibodies in different places and the levels, which can be measured either in that point of care test, like a pregnancy test from your fingertip, or properly in a laboratory, which real lab people like Paul do as part of their work every day.
Hopefully that's answered that question. We have a hot question off the press. Boris Johnson has just announced development of COVID tablets. Any thoughts? It's the first I've heard, and I'm sorry, I've put you on the spot because it seems like it's the first you've heard of it. Right?
I'm not sure what he's referring to there, I'm afraid. So, I mean, the treatment of COVID is an area that's been that the UK again has led in from a research perspective because of the recovery trial. And so we know that if you turn off the immune response in those patients who've got very severe disease, you can treat it. And I don't know if he's talking about a treatment by mouth that people can take at home rather than being in hospital, but I'm afraid I don't know. There is another question that's just asking why the variants are more common in countries like Brazil and South Africa. And if you don't mind, I just pick that up because I think people then think that that's because the vaccine trials were done there. But the reason you get new variants is when you have unstoppable multiplication of the vaccine. So the virus is able to multiply over and over and over again very commonly. So if there's lots of people getting infected, you're more likely to get a variant. And unfortunately, the control of the virus in Brazil has been very poor. And so many millions of people have been infected. It's a huge country with a massive population, but actually there's been really uncontrolled transmission of the virus there. And there was also a media story, because I saw a question on this, saying that lots of young children and babies have had coronavirus in Brazil. And that's another myth. So people think that, is that because that variant is more likely to infect young children? But it's not to do with that. It's just if you have 1% of cases are in babies under 1 and you have 10 million people who are infected, the number of babies who are infected as that 1% is bigger. But there is no evidence to suggest that any of the variants are more severe in babies or young children. And I just want to reassure parents about that because I know it's something people worry about, but we've looked at that quite a lot.
Thank you. Another question from CM. Can you still get and pass on the virus if you've had the vaccine?
Well, the answer is yes, you can.
Right.
The ability to catch the virus is still there if it's present in your surroundings. Now, people often think that vaccines are supposed to protect you against infection. So most vaccines don't do that. And in fact, I think nearly all of them don't protect you from getting the disease. You still, like, if you breathe it into your lungs, it goes into your lung cells, so you still become infected. It's what happens after that. And that's what the vaccine helps with. It stops the virus from replicating madly in your lungs. It stops you having the severe consequences of disease. But also, as a consequence of that, because you have lower amounts of virus in your lung, whenever you cough it out, you spread it less to other people. And it's been shown that the transmission rate is reduced in people that have had the vaccine. The final figures on that will still be, come out in time, but they think it's about 60% reduction in transmission rates. That'll probably be modified, but basically you can still get it. You're less likely to transmit it, but most importantly, for you as an individual, it stops you from having severe illness. So that's why you should have a vaccine.
Right, thank you. Liz, would you like to add anything?
I completely agree. It's unfortunate that we can't just go back to being 100% like we were before, because even though we're vaccinated, until enough people are vaccinated, we have to still be careful. Yeah.
So that would be the whole herd immunity that we keep hearing about, right?
So kind of, and herd immunity is if we vaccinate enough people, then the people who don't respond to the vaccine are still protected because transmission is low. And so herd immunity from vaccination is something that we understand a lot better than the herd immunity that was talked about before, when it was saying if enough people have had the virus, there'll be herd immunity. So it's the problem with that idea is that all the people who get the virus can have complications of the virus. Whereas if everyone gets the vaccine, there are fewer complications, so it's much safer for everyone. Yeah.
So, Hanan, I've just spotted an important question from.
Yes.
So,
go for it.
Long COVID, and there is much negative information on this. Is it something true or just negative press? Well, it is absolutely true. There is a syndrome which isn't just related to COVID. There's a syndrome of post-viral disease syndrome, and this long COVID is likely to be one that will be categorized like that. Basically, you have got COVID, you have had an immune reaction to it, you have had an inflammatory reaction, and that has caused consequences for your body in many different ways. Long COVID, the brain fog, we know mechanisms of how that's starting to work. Long COVID, as in organ damage, we know that is definitely real. Lung damage, we know that that's real. Fertility problems, we know that they're real. So long COVID is definitely a thing. It is not anything to do with negative press or false press. It is a lot of people are suffering from it.
But is it being worked on? Like, is there work in the background on how to treat the long COVID?
Yeah, absolutely. I mean, like all of these post-viral syndromes, there's a lot of treatments already available for to try and help people to get over the inflammatory reaction and the damage that has been caused. But some of it, of course, we'll only know the true extent of this in time. But the number of people who are suffering from it is high. The number of people who go into hospital, then come out again, that have to go back into hospital is also high. So it's not a trivial thing to think about. It's an important aspect of the disease.
And it's related to severity. So we know that the patients who have had developed long COVID over the summer were probably quite unwell back in March and April last year, but not unwell enough to go to hospitals. They had probably a relatively severe disease, but at the time when everyone was trying to stay at home unless they were really unwell, and then they developed these post complications. In the second wave, actually, those people were more likely to go into hospital and get treatment because we were getting oxygen levels on them and things like that. Hopefully less long COVID from the second wave. But with the vaccine, those people won't get that condition at all. And that's one of the reasons why it's not just about your risk of dying. It's not just about your risk of being in intensive care. It's about the risk of you having a moderate to severe infection that can then leave you with long-lasting effects. I think Paul said that very nicely. This is a virus that can affect any part of your body and can leave damage behind it. And that is preventable with a vaccine.
And you may not know these damages for many years, in fact.
Yeah.
You start to have strokes, early onset strokes, and it could possibly be caused by, having a viral infection in your past.
Wow.
Not to scare anybody.
I'm just sitting there trying to think.
Yeah.
Well, we've got an interesting question, and I think one that a lot of people are asking from Cassie, and is it most likely that COVID-19 will never disappear? Is that correct? And what are the plans and strategies moving forward? I think both of you could take this question. So, yeah.
Coronavirus is really interesting because this isn't the first of this type of coronavirus, which is a beta coronavirus, to cause an outbreak. So we've had SARS the first time in 2003, and then we have MERS, which is the Middle Eastern one, which was, I think, in about 2013. And both of those, the one from 2003 did go away completely, but it was contained in a different way. And we think that the most likely scenario is that we will vaccinate as much of the planet as possible, and that transmission will fall, and that there may well be some circulation, but it will have less of an impact because we'll have better protection. And the more vaccinated people there are, the lower the transmission falls, the more likely it is that it can kind of go away. But it's unlikely it'll go away completely. It might just be more that we see less of the bad side of it because people are protected by the vaccines. But yeah.
I'm definitely in two minds about this. I'd love to, as Liz said, the first SARS did completely disappear, even though it had infected quite a number of people. I kind of would hope that might happen, but I feel as though it won't. Like Liz, I feel as though it won't. One of the things that are interesting about coronaviruses, of course, is that we already have some that we are endemic in our populations. There are 7 different ones. If we don't count the original MERS and SARS, there's 5 that are common cold coronaviruses. And they circulate amongst us all the time. They live happily with us in that they just give us a slight cold. So maybe one day COVID-19 could turn into those. That's another outcome. Maybe it could just circulate at a very low level and cause, maybe flu-like illnesses. But viruses always adapt. I mean, one of the adaptations was actually the UK variant. So that adaptation it much more transmissible to us, and so that's why the UK variant has spread so widely. But it didn't actually increase its ability to cause disease. So it was good in that way. It could have been a bad outcome, but it's always possible that it'll go the other way and it'll become less likely to cause disease. So we just have to wait and see. It's one of those things that will develop over time.
Wait and see and have plan B, which is vaccinate as many people as possible.
Plan B, C, D. Hopefully not. Fingers crossed.
Well, a question then for that would be how can someone talk to people that are hesitant about getting the vaccination? Because there's good media about it, there's bad media, but how would you actually speak to someone who's hesitant about receiving vaccination?
Sure. The important thing about all discussions of vaccines, and if people are hesitant, is there's no problem in being hesitant. If you have questions about something, you should always ask them. And if that's hesitancy, then that's hesitancy. But it's our job, really, and it's your doctor's job to say to you, give you the facts, give you the information so that you can decide for yourself. And we can try and show you that this is of benefit to you and your community. So being hesitant is not a negative aspect. Being an anti-vaxxer and having an agenda of being anti-vaxxers is what causes this damage. And it also causes a lot of people to become more hesitant because all of these social media myths that we have to try and counter are the things that are causing people to not want to have the vaccine.
Yeah, I agree. I think that we're all human, and we're naturally going to want to know all the facts before we make decisions. And I agree, our job And the healthcare job is to make sure the information is there for people to read about, to interpret it if they don't understand what's written, because sometimes we're a bit too sciencey, and to try and reassure you. I'm really grateful. My dad and my sister and my husband and I have all been vaccinated, and I would recommend it to anyone I know and love, because I think I've seen firsthand, unfortunately, on the wards, what the virus can do to people of all ages and all colours and all shapes and sizes. And the vaccine is undoubtedly the safer way to develop a protective immune response to the virus than having the virus itself.
And of course, us being on things like this to try and show you that we're not the big bad people. We're not people that are trying to pull wool over your eyes. We're trying to be open, transparent, give you any information that you need. And if you're hesitant, we'll try and answer your questions.
Thank you. I'm trying to pick. I should be good at this, shouldn't I?
You are good at it.
Is there a question that I think it's all at the moment, the concern about the blood clots, fertility, the young children as well, when they will be offered the vaccination. Like you said earlier on, is that there is a clinical trial at the moment, but will this be a way forward now for our lives where we will constantly have to have the vaccination every year, like the flu jab? One of the questions I get asked a lot as well, do you need to have the flu jab to have the vaccination? Do they go hand in hand or not?
You should have both, so they are different. So a vaccine is specific to one bug, and so the flu vaccine is specific to the flu vaccine is specific to the flu, and the COVID vaccine is specific to COVID. And so come the autumn, you will still need to have a flu vaccine before we go into the winter. We didn't have a flu season this year, probably because there was no travel and people wearing masks and washing their hands like they should have been all along. And I'm so happy for that. And so they will still need to have that. I think that generally speaking, people associate vaccines. I think most of us, kind of people who aren't old enough to get the vaccines that you get when you've retired and in your late 60s, mostly we think about vaccines as something we give to young children. And I think that's why there's so many questions, because it's the first time since you were a child maybe that somebody's offering you a vaccine. So it's this really strange thing, isn't it? Where actually we're doing that because this is a new bug. And so we need to do that to prevent its spread. But we actually give vaccines in the vaccine community and in GP practices and in Boots the Chemist and in other pharmacies all the time. So we vaccinate people all the time against a variety of things. If you go overseas, there are travel vaccines that you get. And so vaccines are a really normal part of our life. They're probably one of the things that's made the biggest difference to dying of any intervention that we've made from a healthcare perspective, apart from clean water, which is a really fundamental thing. Vaccines save so many lives and have done for the last kind of 200 years since they were first introduced. And people have been worried about them since they first came out. It's just human nature to worry about new things. So it's normal to worry about this, but to be reassured, this isn't a completely new phenomenon. This is just a slightly different way of, because we put a new virus in it. It's a technology that we've been using and doing things like this for a long time.
Paul?
Perfect. Yeah, absolutely. A lot of people say things like, I'm not unwell. I'm a healthy, younger person, not me, but young person. And therefore, why should I take this vaccine? And the answer to that, of course, is apart from long COVID and the complications of it, having COVID, you should do it for your family, for your community, to try and get our lives back to normal, because stopping the spread of this disease throughout the country will enable us to go about our lives in a more normal way.
So there's a couple more questions that have come in on the side. One is it possible to talk about the 3 weeks, the 12-week intervals, and if you miss the 12 weeks, what happens? So this all came about because when we were designing the vaccine trials, we knew when the vaccine trials were being designed, the minimum period that we thought would be a good time between 2 doses was 3 weeks. And at the time, there was a bit of a rush. We really needed to know if these vaccines were going to work. And so the vaccine trials were designed to do them as quickly as possible. And 3 weeks was the shortest, safest period between the 2 doses that could be given. In actual fact, for lots of other vaccines, it's hard that they both start with a V. For lots of other vaccines, we do different intervals. So, for example, hepatitis A, which is a vaccine you might get if you go overseas, it's normal to give those 2 doses 12 weeks apart because we know that's the perfect time frame to get a really good response that lasts for years and years. And so, actually, the moving of 3 weeks to 12 weeks may actually be better. And there is some data emerging to suggest that's the case, and Paul maybe comment on that in a moment. If you go past 12 weeks, it's not so much that you might need then have to have a 3rd dose. I think that will still be effective. If you go a lot past 12 weeks, then you may need to have a 3rd dose. And I think those are things that we're still looking at. There are trials that actually are specifically asking all of these little questions, but they weren't asked the first time around because we wanted to get really good safety data and efficacy data as quickly as possible.
Paul?
Yeah, exactly that. It was a very practical decision, the 12-week thing for the UK, in that we had a number of vaccines. We wanted to get a maximum number of people their first dose. And exactly as Liz says, after 12 weeks, it's kind of unknown as to whether it would still be as good as within the 12-week period. I think it would be fine, but boosts can't do any harm.
Yeah.
Thank
so
you.
There's another question about monitoring for vaccine side effects and long-term effects that we talked about a little bit earlier. So there's really good surveillance in place to look for these really rare things that can only occur, maybe 1 in a million. And so there's a reporting system after vaccination that your GP, or if you went to A&E with a problem, that they would report it.
Oh, so there's a really important question here from Mycon. The biggest thing stopping my friends and family about taking the vaccine, it was not tested within the BAME community. So it wasn't specifically tested within the BAME community, but there were people who were participants in that trial who are members of the BAME community, and there was no reason for us to see, there was no difference seen in the immune responses in people from those communities. So it is likely that those people would respond in a very similar way to the main population, and that they would be protected if they got this vaccine.
Yeah, and some of the vaccine trials were done in other countries, including South Africa and Brazil, where there are lots of people of different ethnicities, including Black and East Asian and Southern Asian populations, who've all had very similar efficacy to the studies that were done in America and in the UK. So we don't think that your background ethnically will make any difference to how well you'll be protected from the vaccine.
Right. Thank you. We're actually coming towards the end of the session. I know there's many questions that haven't been answered yet, but they will be answered after this session. Liz, Paul, I want to say a massive thank you. You both have been amazing, and I think we could keep you here for another hour or so to ask more questions. But I'd like to say, Liz, do you have any final words for us?
Just don't be afraid. I think that this is the one thing people ask a lot is this has happened very quickly. And that's because people, the stages that we did in the trial, we did alongside each other rather than one after each other. And because there was political will to do so and lots of money put behind it. So I think that we're very confident that the safety steps that are in place in vaccine development were all used, and that there's no reason to be worried about these vaccines, and they've been given to millions and millions of people, and we know that they've been safe.
Thank you, Liz. Paul?
I second that. And thank you very much for hosting this so nicely, Hanan.
Yeah. Oh, thank you. Thank you. And thank you to our audience as well. They've been amazing. The questions have been fantastic. Sorry, once again, if I haven't pronounced anyone's name right. You two have been amazing. So thank you so much. Really appreciate it. And stay safe, everyone.
Take care.
Bye.
Bye.
Thank you.
Bye-bye.
Bye.
Bye.